Part 5 Sports Medicine. Upper extremity, shoulder, elbow, forearm, and hand. Common shoulder pathology. Pathology, presentation, special tests, diagnosis, and management. Subacromial impairment syndrome, pain with abduction, internal rotation, and overhead activities, swimming, throwing, leads to rotator cuff tear. Near test, Hawkins test, and painful arc. Diagnosed by MRI, managed by conservative corticosteroid injection. Rotator cuff tear. Result of trauma, fall on outstretched hand, FOOSH, and or chronic impingement. Most common, knee torn as supinatus for 15 degrees of abduction, causes weakness and pain with abduction and external rotation. Test is Job, empty can, and drop arm. Job test, drop arm test. Diagnosed by MRI, management, surgery for full thickness tear or failed conservative treatment. Bicep tendinitis and rupture. Tendinitis or use injury from overhead activities or sports in adults greater than 40 years old with impairment, associated with other shoulder pathology, labral tear, rotator cuff tear in elderly. Most common proximal non-head or bicep and vestibular grooves, rupture, pain, audible snap, ecchymosis, visible bulge, Popeye's eye sign. Test special test speed Yergason and diagnosed by clinical ultrasound or MRI can help confirm. Tendinitis conservative corticosteroid injection, rupture, surgical reattachment in young patient. Adhesive capsulitis in frozen shoulder is caused by presentation. Active and passive range of motion are restricted greater than 50% in all planes, especially abduction, extension, rotation. Stiffness exceeds pain. Result of chronic inflammation, fibrosis, and contraction of joint capsule. Risk factors: severe trauma, diabetes mellitus, cerebrovascular accident, hypothyroidism, female, age greater than 40 years. Now, limited AROM and PROM, range of anterior motor and posterior motor is the other test. Now, clinical imaging can help confirm diagnosis and physical therapy, manipulation under anesthesia, OMT, Spencer technique. Now, AC separation, pain, lapel pain or AC joint, acromioclavicular joint, and adduction of arm. Result of massive force on adducted arm, usually a fall onto the tip of the shoulder, football tackle, wrestling throw, ice hockey check. Now, its test is cross-arm adductor test, and confirmed X-ray, type 1 to 2, no clavicle displacement, conservative wrestling, type 3 to 6, surgical open reduction, internal fixation, OIRIF. Common shoulder pathology continued. Pathology presentation, special test, diagnosis, management. D of glenohumeral joint, uncommon, caused by trauma or repetitive use, pain with abduction and internal rotation. Special test is limited AROM, anterior range of motion, and posterior range of motion. Diagnosed by X-ray. Management conservative or arthroplasty replacement. Labral or slap, superior labral, anterior to posterior tear. Presents similar symptoms to shoulder instability, pain, knocking, clicking, or use injury from overhead sports associated with bicep tendon rupture, dead arm syndrome, shoulder fatigue, pain, numbness, and or paresthesia in throwing position or overhead position. O'Brien load and shift test, diagnosed by MRI, managed by physical therapy for strengthening, arthroscopic surgery for refractory cases. Glenohumeral dislocation presents anterior, most common greater than 90%, involve risk of axillary nerve damage. Arm held in abduction with external rotation, commonly caused by FOOSH. Posterior uncommon, less than 10%, results of seizure and or electrocution. Arm held in adduction with internal rotation. Spell test observation, apprehension test. Diagnosed by MRI, X-ray initial, MRI most accurate. Managed by reduction followed with a sling, surgery for repeated occurrences. Clavicular fracture, caused by presentation trauma, fall on outstretched hand. Test palpation. X-ray angiogram for vascular injury. If neovascular compromise is suspected, subclavian artery and brachial plexus. Now, treatment simple arm sling open reduction internal fixation for severe displacement. Nearest test, subacromial impingement syndrome. Place one hand on patient's scapula, other hand on one arm. Internally rotate arm and forcibly flex arm to ear. Pain is positive test. Remember near to the ear. Near test. Look here. Hawkins-Kennedy test, subacromial impingement syndrome. Place the patient's arm at 90 degrees of floor flexion with the elbow flexed 90 degrees and then internally rotate the arm. Pain is equal to positive test. Job or empty can test. Test for rare cup tear supraspinatus. Have pain and flex arm to 90 degrees, abduct to 45 degrees, and internally rotate with thumb down. Resisted flexion causes pain, positive test. Now, cross arm adductor test. Acromic flexible joint separation test tear. For elevating to 90 degrees and active adduction. Pain is equal to positive test. Lateral tennis elbow. The most common cause of elbow pain. Pain over the distal lateral epicondyle that radiates to the forearm and increases with repetitive supination or forearm extension, results from microtrauma to the common extensor origin or external tensory carpi radialis brevis (CRB), often causes weakness in grip strength, common in the dominant hand of younger patients, 40 to 55 years old, who perform repetitive motions, carpenters, plumbers, and tennis players. Medial golfer's elbow, little leaguer's elbow, pitcher's elbow. Pain over the medial epicondyle that increases with repetitive or excessive forearm valgus stress or pronation motions, golfing, pitching, result from microtrauma to the common flexor tendon. Diagnostic test. Diagnose epicondylitis with physical examination. Lateral pain with passive wrist flexion or resisted supination or forearm extension. Medial pain with resisted wrist flexion and pronation. Treatment is conservative and shade rest and physical therapy in elastic chondrophore sleeve and corticosteroid injection into common tendons. Lateral are effective in greater 90% of patients. The Quervain tenosynovitis is presents as pain and tenderness over the right side of the wrist. The Quervain tenosynovitis is an overuse injury caused by repeated thumb abduction and extension. The pain results from inflammation of the tendon of the extensor pollicis brevis and adductor pollicis longus, which are the first compartment of the wrist. Anatomic self-walk. Look for a new mother constantly holding her baby. Falling and texting are other common causes. Diagnostics, test, and treatment. Finkelstein test, best initial test. Tap and flex the thumb into the palm, making a fist, then ulnarly deviate the wrist. This test is positive and it reproduces the pain. Treatment is conservative, thumb spica splint, and safe and corticosteroid injection. The Quervain tenosynovitis, overuse of abductor pollicis longus, extensor pollicis brevis. Finkelstein test. Thumb is tucked inside finger/fist and wrist is ulnarly deviated. Pain is positive. Scaphoid fracture. Scaphoid fracture is also known as fall on outstretched hand (FOSH) because it is caused by a fall or trauma on an outstretched and distorted flexed wrist. The scaphoid is the most commonly fractured carpal bone, greater than 70%. This injury involves the risk of avascular necrosis of the scaphoid due to unusual blood supply that flows distal to proximal from the radial artery. Look for pain with palpation or the anatomic self-walk. Diagnostic test and treatment. Plain X-ray, best initial test. The fracture is not seen on imaging but is suspected. Treat as a fracture. Immobilize the wrist and thumb spica cast for 10 to 14 days and then repeat X-ray to confirm fracture. MRI or CT can make immediate diagnosis but is not the best initial test. CT is the best test for patients that are still symptomatic up to 4 to 6 weeks of treatment. Treat non-displaced fracture with thumb spica cast for 6+ weeks. Treat displaced fracture greater than 2 mm with open reduction internal fixation.